This is the community health service delivered by the Prince Albert Parkland Health Region, Collaboration, Research, and Innovation. This study was carried out by the Health Studies 300 class at the University of Regina in the winter 2012 semester. My name's Andrew.
And my name is Michelle, and we will take you through some of our research findings. Now I'll just provide some background information regarding the Prince Albert Parkland Health Region. The region is the third largest health region in Saskatchewan, and it's the most densely populated health region. Here's just an outline of the jurisdiction of the Prince Albert Parkland Health Region. The Prince Albert Parkland Health Region has a higher Aboriginal population compared to Saskatchewan. The population is younger, poorer, less educated, and more accident-prone compared to Saskatchewan and Canada. The vision of the Prince Albert Parkland Health Region is healthy living in healthy communities. The region is ethnically, culturally, economically, and politically diverse. Although diversity enriches the community, it also presents a great number of challenges for the health region. There's a growing awareness that the determinants of health play a stronger role in the health of a population compared to medicine and health care. The social determinants of health include income, food security, education, unemployment rate, family structure, water and air quality, personal health practices, and coping skills. Since the Prince Albert Parkland Health Region is such a diverse region, it is important to incorporate a culturally sensitive and interactive approach to healthcare when addressing the social determinants. Healthcare cannot be a one-size-fits-all process. Canadians are proud of our universal healthcare system, but there are some problems within it, such as access to those services. In fact, Canada then only scores a B for overall national health performance. Lifestyle choices play a critical role determining the health quality of citizens. By adjusting our lifestyles, we can reduce the risk of premature deaths due to disease and the costs associated with them. It is immensely important to deal with the factors that contribute to health outcomes that are not covered by the universal healthcare system. This can be done, for example, by addressing our eating habits and our physical activity levels. Preventing health problems from occurring will, in the long run, be cheaper than trying to treat them. The Conference Board of Canada recommended that Canada's healthcare system place more emphasis on collaborative, interprofessional care, primary practices, and population health approaches. Therefore, we should tailor our services towards preventing as well as managing chronic diseases. Our class has researched some best practice options that could save money. These options are upstream approaches. That is, they target the social determinants of health and address existing problems as well as aim to prevent risk factors from developing into health problems.
When education was studied in PAPHR, it was found that there was generally lower attendance rates among First Nation and Métis students when compared to non-Aboriginal students, with problem areas in math and literacy. The biggest issue is student transiency. Student transiency is described as families who frequently move. This affects students because they fall behind and miss a full year's curriculum. Schools are also unprepared for a sudden student arrival. This graph shows the moves made by First Nation families in PAPHR. Best practice option 1 involves improving student transiency through electronic, transferable academic records and support systems for students who move. This would prepare schools for new students, as well as students will not fall behind. Option number 2 is a current program called the First Nation Student Success Program, which provides funding for schools and students from kindergarten to grade 12. The funding implements student success plans, student learning assessments, and performance measures, which improves the attendance of First Nations and Métis students. Best practice option 3 is to improve mathematics, science, and literacy through project-based learning, real-world problem solving, technology, and culture. This will keep students engaged and curious and develop their critical thinking skills. They'll feel more comfortable in the academic surroundings.
Food security exists when there is universal access to nutritious food in order to meet the needs of a healthy lifestyle. A lack of food security can lead to diet-related diseases. Poverty affects food security as it is harder to access or afford nutritious food. Best practice option number 1 is to implement community gardens such as in parks, schools, churches, and rural areas. This best practice may maximize utility of vacant land, reduce diet-related diseases, improve access, and lower cost of more nutritious food. Best practice option number 2 involves an intervention of convenience stores. This intervention promotes healthy food alternatives at a cost equal to or less than the products they replace. Promoting healthy food in small stores increases access to healthy food in low-income and rural areas. Best practice option number 3 involves implementing educational cooking programs in schools and community centers. This option involves teaching students and families how to cook healthy meals and teaches them how to budget and shop for healthy food. This option works to reduce diet-related diseases and improves learning and school performance.
Gestational diabetes mellitus occurs only during pregnancy and is the most common problem for Canadian pregnant women. It poses a risk both to the mother and the baby. It is estimated that GDM has a personal cost of $2,500 per year per person. It also costs the government $26,000 to $35,000 per woman per GDM pregnancy, and $4,500 to $13,000 per child born to a GDM mother. Best practice option 1 involves promoting lifestyle changes. Community exercise and cooking programs or providing free gym memberships to pregnant women would improve nutrition and fitness of women and reduce the risk of developing GDM. Best practice option 2 involves education and intervention. They offer awareness campaigns, recipes, offer education in different languages, and provide DVDs of physical activity and cooking instructions. This will increase awareness about GDM and empower women to manage weight or GDM at home. Best practice option 3 involves culturally sensitive care. This would involve elders helping to educate about GDM and promote pre-pregnancy testing, share experiences with the community, and create targeted programming. This would increase education and awareness, bridge language and culture gaps, and build community cohesion. Best practice option 4 is dietitian counseling and nurse educators. Nurses at clinics can teach how to test blood glucose levels and promote fitness and nutrition, as well as educate on preventing GDM complications. This would reduce the burden on hospitals and empower women with GDM. Best practice option 5 is the GDM Eradication Task Force. They study the prevalence of GDM in communities and partner with nutrition and recreation services. They suggest interventions and programming to health regions. This would increase understanding of GDM and improve access to services.
When it comes to vaccinations, in order to achieve effective prevention, there needs to be a 95% vaccination rate. However, in PAPHR, the rate is less than 70%. A current practice that is implemented in Saskatchewan is SIMS, which works to increase efficiency. However, there is an unrepresentation of First Nations people because on-reserve administrations are a federal responsibility and are not included in the provincial database. Best practice, option number 1, works to target one vaccine at a time and keeps a list of unvaccinated individuals. It also records those who were vaccinated and those who refused. This option works to increase the target vaccine by 74% and positively affects other vaccination rates. Best practice option number 2 involves giving the child reminders about immunization at their first birthday. It also involves giving an incentive in the form of a birthday present. This option works to improve community relations, and to increase the immunization rate to 94%. Best practice option number 3 is to provide quarterly reports on vaccination rates and gives recognition for physicians and nurses who contribute to the highest vaccination rates. This resulted in higher vaccination rates by a more informed and purposeful team of healthcare workers.
Falls are the most common injury for elderly people, especially rural seniors. Best practice option 1 is the Lifeline Medical Alert Service. It is a button worn around the wrist or neck and is easy to use. It provides independent living in seniors and reduces facility bed use and costs. Best practice option 2 is the community-based osteoporosis and fall prevention program based in Sweden. It has a hazard checklist, posters, and education programs, and has walking, weight, and bearing exercise activities. It reduces forearm and hip fractures. Best practice option 3 is the Saskatchewan Falls Collaborative Program. It's a 3 learning stages over 10 months and has cost-free enrollment. There is a 20% reduction in falls and injuries in the elderly. In PAPHR, there is poor dental health at young ages. Poor dental health leads to damage to teeth and gums, heart disease, poor quality of life, and lower life expectancy. Preventative health is very inexpensive. Best practice option 1 is the China Education Program. It improves social awareness and the important dental health through social media and awareness days. In China, it improved the rate of daily teeth brushing from 30 to 80%. Best practice option 2 is the Region of Peel Mobile Dental Clinic. This travels to remote areas and provides free dental services to children of low-income families. In 4 years, they served 1,600 children. The Mobile Dental Clinic travels to rural communities and has a dentist and hygienist who provides cavity fillings, dental sealants, and descaling on children who cannot afford regular dental care. Best practice option 3 is the continued use of water fluoridation at optimal levels. Even though Saskatoon is only 2 hours from Prince Albert, they have far less cavities among their youth population due to the higher levels of water fluoridation.
Traffic safety needs to be addressed in PAPHR since car accidents are one of the top 5 causes of death and cost the region millions annually. Improving traffic safety would reduce influx of people into hospitals. The first best practice option is to construct a traffic circle. This would force reduced speeds and decrease the severity of collisions. Best practice option number 2 recommends bicycle education in schools. This would teach youth the rules of the road, making them more conscientious drivers in the future. The third best practice involves driver's license retesting by age 70 and every 3 years thereafter. This would ensure the driving ability of seniors and decrease costs associated with accidents. Housing as a social determinant of health contributes to physical and mental health. Practice option number 1 provides advocacy and legal advice to renters and homeowners. It could offer discounts to those renting to own and also aims to improve social skills and provide job training. Overall, housing is made more affordable to the disadvantaged. The second best practice option involves converting commercial buildings into transitional or temporary housing. This option provides less costly housing and can also support struggling addicts.
Current Saskatchewan programs are the early childhood intervention programs that focus on children from birth to 3 years of age. Various government programs focus on intellectual, emotional, physical, and spiritual development. Best practice option 1 is the Virginia Individual Family Service Plan, which puts family at the root source of intervention. They develop family routines, comprehensive family data, and have goal setting and assessment, which changes at the family level. Best practice option 2 is early childhood interventions from Europe, which detect causes of development delay, dynamic assessment of needs, goal setting with child and family, and professional evaluations. This practice develops independent children. Best practice option 3 is from Australia, the National In-Home Childcare Association. This provides childcare at home for families with limited access to other childcare services and childcare for families with special needs. The incidence of HIV and AIDS rates in PAPHR has doubled for male and females between 2005 and 2009. There are many contributing factors, including mobility, poverty, and high-risk behaviors such as intravenous drug use. The net economic loss of people recently infected with HIV is 1.3 million per person. The best practice option 1 is the supervised injection sites found in Vancouver. They strive to decrease adverse health, social, and economic consequences of drug use. It doesn't require abstinence from drug use, and provides a needle exchange program. This decreases injection and discarded needles in public areas, a decrease in sharing needles, which decreases new HIV infections, and it prevents 36 new cases of HIV and 3 deaths annually. Best practice option 2 is a collaborative HIV prevention and adolescent mental health program, also referred to as CHAMP. The family role models education and behaviors to young children, which increases HIV knowledge, provides authoritative parenting with comfortable discussions about sex and risky behavior, which in turn prevents risky behavior. Thank you for taking the time to listen to our research. This presentation has been a very brief overview of our full report. To view our full report, please click the link in this presentation or in the description below to be redirected.